Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Product Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Shelley, would you like to take a moment to introduce yourself?
Hi, yes, my name is Shelley Frade. I am an intern here at the Blum Center, and I am from UMass Lowell in undergrad.
Thank you, Shelley. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. You have been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for it in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Shelley, who will introduce you all today's guest speaker.
So our guest speaker today is Dr. Kozin, who is a fellowship-trained and board-certified otolaryngologist specializing in adult and pediatric otology and neurotology at Mass Eye and Ear. He is also an assistant professor at Harvard Medical School. Dr. Kozin's clinical interests include the surgical management of chronic ear disease, conductive hearing loss, cochlear implantation, and tumors of the lateral skull base. Dr. Kozin also performs endoscopic ear surgery for a variety of surgical conditions and regularly lectures on the subject. He joins us today to give us a talk on hearing loss, hearing aids, and tinnitus. Please join me in welcoming Dr. Kozin.
Well, good afternoon, everyone. Thank you so much for the kind invitation. Looking forward to chatting a little bit more about hearing loss, tinnitus, and hearing aids. Let me go ahead and share my screen. So what I tried to do is put together sort of a 101 on hearing loss. Let me just make this a little bit louder, just sort of like a brief overview and try to address some of the very common questions that I get when patients see me in clinic. All right, so this is where I practice. It's at 243 Charles Street. It's pretty much attached to Massachusetts General Hospital. We're a standalone institution where we provide all forms of otolaryngologic care, so ear, nose, and throat care. So anytime you want to see an otolaryngologist who's part of MGB at Mass Eye and Ear would be part of this building. There are also satellites all over, I would say, the New England area at this point, and many of those providers will also see patients for hearing issues, tinnitus, and hearing aids as well. So you don't always need to come into Boston for those issues, especially some of the more maybe basic issues. But if you need subspecialty care, you probably end up somewhere here. So in terms of what we'll be discussing over the next, I put it, 40 minutes or so, and then leave some time for questions, are the mechanics of hearing. What is hearing testing? What to expect if you do have a hearing test, hearing aids, a very brief overview on tinnitus, and then I think it'd be nice to leave some time for questions to address anything that you'd like to chat about. So I think just to get everyone on the same page, it's important just to describe how we hear. So sound, this is sort of in this case, this slide is, musical sound goes in and vibrates the eardrum. This is in yellow here. And these three small bones of hearing. This mechanical energy, which is sort of vibrations, is then converted into electrical impulses, what neurons might encode in the cochlea. This is the main hearing organ in red. And then that sends a signal via the hearing nerve called the auditory or cochlear nerve to the brain. And then it just goes to the rest of the brainstem and to the rest of the brain. So when we think about the ear, we often think about this, which is the eardrum, and this really is the beginning of the auditory pathway. Many people might be surprised that you actually can do ear surgery. It's not infrequent in my clinic that people are amazed that you can actually do surgery on the ear, but that's pretty much what we do day in and day out. And I hope no one is particularly squeamish. I don't think there's really much blood on this, but you can see here is what we do in a lot of types of ear surgery is pretty much lift up the eardrum. You do this, it's endoscopically or microscopically. We're talking on the order of millimeters, and you're able to get to some of the organs that provide for hearing. And in this view, you can see the second bone of hearing called the incus, or that's sort of the medical term. The stapes or the stirrup is oftentimes what it's called in the lay literature. And then you have the beginning of the inner ear, which sends a signal to the brain. So it's an incredibly complex system that allows us to hear. And I'd say unlike other systems, maybe like the eyes where you can blink, this never turns off. So we're pretty much hearing 24/7 from the time that you're born. So even though it's going 24/7, it's very common to have hearing loss. It's one of the most prevalent health conditions of really all ages, but particularly some of the older members of our society. Nearly 16% of adults in the US report hearing issues. It's more prevalent to have hearing loss in men than in women. It's not exactly known why this is the case. It might be theorized due to some of the professions that men traditionally do outside that might have noise exposure. And it's incredibly common. We think of things like diabetes or cancer as being common, but hearing loss is nearly twice as common as those other disorders. So there's a wide range of causes of hearing loss. We could probably spend weeks talking about different forms of hearing loss. But when you see the doctor for hearing issues, he or she will generally categorize it into two main camps or categories: conductive hearing loss or sensorineural or inner ear hearing loss. And I'll describe that a little bit more on the next slide. But the things to think about in terms of sensorineural hearing loss is the most common types are aging. Nearly everyone, as they get older, will lose hearing. My mentor once would say to his patients, if you keep having birthdays, you'll keep losing hearing, and that's generally true. And noise exposure is probably the second most common cause of inner ear or sensorineural hearing loss. So conductive hearing loss is really due to things like wax, ear infections, perforations or holes in the eardrum, or issues with the bones of hearing. If they're stiffened or absent or degraded for some reason, or there's maybe a mass there, that's a conductive hearing loss. Basically, sound cannot conduct through the external auditory canal in the middle ear to be transmitted to a signal in the inner ear. Inner ear forms of hearing loss, as I described on the prior slide, are things like aging and noise exposure. There's an issue with the sensory cells of the inner ear. You're born with a finite number of them, and when you age, one by one, they go away and they basically die. And so when you have a loss of those sensory, sometimes called hair cells, you end up losing hearing, and that occurs quite gradually. So when you go in to see an otolaryngologist or an audiologist or even your primary care doctor, they'll start with a basic exam. They'll look in your ears to make sure there's no blockages. They'll oftentimes look in your throat, sometimes issues with other aspects of the head and neck, including the sinuses, can also cause types of hearing loss. So they'll basically do a full physical exam. And then depending on what they find, they'll often send you to a hearing test, or often called audiometry. This is a completely non-invasive test. For those that have never done it, you basically go in a soundproof room and they do 3 different types of things for the most part. The first is a type of tonal hearing test where they basically say, can you hear this? And because you're in a soundproof chamber, you can't really say anything. So you basically raise your hand when you can hear something. And that allows us to understand at what threshold you can hear something and what tone. So you can think of hearing as sort of like the keys of a piano. And so they'll test low frequencies like the left side of the piano, high frequencies like the right side of the piano. It can pretty much create a map of where you might be missing some frequencies or hearing. arguably more important than whether you can hear tones or not, or whether you can understand words. So the analogy that I commonly give for this word testing, it's sort of like an eye test. When you look at the eye test, you can often see letters, but you might not know what those letters are. So that's sort of a clarity piece. So they'll test words and they'll have you repeat that word. And then this doesn't always occur, but sometimes if they're concerned about some sort of conductive hearing loss, they'll measure the pressures, how well your eardrum moves in response to pressure. Again, you don't really feel it. It doesn't cause any pain. It's really on a microscopic level. And then they'll be able to understand maybe there's a hole in your eardrum, maybe there's fluid there, and they'll be able to assess that using that test. So really 3 parts to any common hearing test. So oftentimes I'll be asked, when should you have a routine hearing test? The most common responses for this is there's no US guideline on when you should get a hearing test. So unlike, say, mammography or colonoscopies or blood work for elevated cholesterol or blood pressure, the US Preventative Task Force does not say at age 55, you should have a hearing test. For better or for worse, I think it's probably for worse. It's really up to you to figure out when you might need a hearing test. So usually if you've had a hearing loss in the past, we generally want a repeat hearing test every year or so. That's highly variable, but generally that's a good rule of thumb. Oftentimes, if you feel like you're asking for repetition or saying what more often than you used to, that's probably a good time to get a hearing test. Usually it's not yourself that's figuring that out, but maybe a spouse or a friend or colleague that's saying you're missing some things, or you're missing parts of the conversation. That might be a good time to get a hearing test. If you're missing things in noisy environments, which is very common as you age, it might be reasonable to get a hearing test. And then the last bullet is what we just spoke about. This is probably the most common thing, is somebody is telling you that you're missing things, and it's probably a good idea to test your hearing. So that's when you should have a routine hearing test. Really no urgency, but over time you feel like you're missing more and more. Then there's the consideration of when you should have an urgent hearing test, maybe within a day or two. So there are certain conditions where you could lose your hearing suddenly. That we don't know typically why this is the case. We often think it might be due to a virus or a small little blood clot, like a stroke in the ear. And so if you ever have a sudden loss of hearing, your ear feels blocked or full, especially if you're not having a upper respiratory tract or say cold at the same time, sudden tinnitus that really doesn't stop, or dizziness, that's when you really want to call your primary care doctor and say, I have a sudden hearing loss, my hearing seems off, and let your primary care doctor sort of direct next steps. I will say Mass Eye and Ear has a 24/7 emergency room. It's different than the one at Massachusetts General Hospital. It's a standalone ER. So if there's any concerns for hearing, you're always welcome to stop in there and receive subspecialty care right away. So patients will often come to me with at least some degree of hearing loss, and they say, well, I'm okay, and thanks, and I'll let you know if anything changes. But what I often will tell them in this situation is hearing loss is really more than hearing loss. You might have difficulty localizing sound. You don't know maybe where sound is coming from. If your spouse is in another room or you're in a noisy environment, you just might not know where sound is, and that can be quite troublesome. Challenges in noisy environments, sort of like I mentioned, not just knowing where sound is, but just not being able to pick up individual voices. It can be quite overwhelming and challenging to sort of enjoy those social settings if you have a hearing loss. Quality of life, there are numerous studies that show individuals with hearing loss have decrements in other areas of quality of life and satisfaction. So it's certainly worth addressing. Over the last 10 or 15 years, there have been studies that show hearing loss can cause social isolation and is associated with cognitive decline. I get this question quite a lot. Does hearing loss lead to dementia? And the short answer is no, but it probably leads to factors that might lead to dementia, meaning if you have a hearing loss, you might be depressed, you might be socially isolated, you might not engage, and those things certainly are more likely to cause cognitive decline. So the research on this is ongoing, but again, hearing loss is more than hearing loss. And I'd say the last thing, which is probably most important in this whole list, is cognitive fatigue. People who have hearing loss spend a lot of time and energy trying to listen. They're reading people's facial cues, they're reading lips, they're really concentrating. And at the end of the day, especially if you're in social settings, that's exhausting. And so it's cognitively fatiguing. And so what I tell people when they're often on the fence about hearing aids is you might get a little bit of energy back at the end of the day, that it's not just about hearing, but all these other things that come with social types of communication. So here's a little bit about hearing aids. For run-of-the-mill hearing loss that might be age-related, there's really a wide array of hearing aids. Everything that is sort of hidden in your ear canal and are placed there, once a month and removed to replace a battery, to ones that more traditionally are placed behind the ear. People often ask about batteries. They're often disposable or rechargeable. There's really no right or wrong answer to which one you should get, but they're both available. And these are generally intended for daily use. Again, I'm talking about my mentor things I learned along the way that I now use with my patients is my mentor used to say to his patients, hearing aids don't work if they're in the sock drawer. So you really want to use them every day, because if you don't use them, you're not really used to using them and they're really not providing much benefits. They're really meant to be used all the time. A question I get is, well, if I use hearing aids, then my hearing is going to get worse. I'll become, quote, dependent on them. And that's absolutely not the case. If you need glasses, you should wear glasses every day. If you need hearing aids, you should wear them every day. They really do improve your quality of life. And there are no studies that I'm aware of that if you use hearing aids every day, that your hearing will get worse. If anything, they're really what you need to improve your day-to-day functioning. Most hearing aids these days, if they're of a certain quality, will have some sort of Bluetooth or audio streaming capacity. Many people wear them as opposed to, say, the Apple earbuds. A lot of the times you can control them from your phone. So there's sort of a remote access to, change volume or change pitches. Generally, the larger ones have more features as a rule of thumb, but even some of the smaller ones have the capacity to have some of these added features as well. Some might want to know why you would want a larger one rather than a smaller one. What I tell patients, most people these days, for aesthetic reasons, the hearing aids, even worn behind the ear, are really difficult to see unless you're fully bald, I would say. A lot of the time, the hair just around your ears will cover the hearing aid, and unless you're looking at someone directly from the side, it's pretty hard to see when you're looking at them sort of face on. But beyond that, you can really have a much more powerful device if it's larger. And the reason isn't so much the battery, but the speaker and microphone are separated in space. So you generally might know that if you bring, let's say, a microphone next to a speaker, you get this huge feedback. Basically, it sounds like a screeching noise. That's similar with hearing aids. You can only have so much space between the speaker and the microphone. And if something is worn behind the ear, you can make it much louder and you won't get that feedback effect. So that's one of generally the main reasons for that. There are other types of hearing devices. We'll call them implantable hearing devices. On the left hand side of the screen, this is a cochlear implant. So that's really not a hearing aid. That is a device that's placed in the inner ear for individuals where their hearing is so poor that a hearing aid will not be of much benefit. So basically, you could play sound up to the level of, say, 110 decibels, which is, someone sort of screaming on the side of the street. But even if you get that volume, remember I spoke about those clarity scores, your brain will not be able to interpret that information. It'll just sound like random sound or noise, but you won't be able to understand any words. So at a certain point, your clarity scores become so poor that a regular hearing aid won't work, and you go for a cochlear implant, and that's a surgically placed device. Other individuals opt for what's called a bone-anchored hearing aid. So this is a hearing aid that's effectively placed under the skin and will vibrate certain parts of the skull or those bones of hearing. Many people might have heard of bone-anchored listening devices for, say, runners, where you sort of wear it in front and it sort of vibrates your skull. This is a very similar type of technology. No one else can hear it. It's just literally vibrating your skull, and it tends to work. We generally recommend this for people for a number of reasons, but oftentimes for anatomic reasons that we can't place a hearing aid, or they just generally like the quality of the sound. And so you're welcome to try on one of these hearing aids, over the skin to have a general sense of what it might sound like. Admittedly, it will sound much, much better when it's placed surgically because it's directly stimulating the bone itself, but you can get a general sense of what it might sound like. Then everyone also asks a little bit these days about over-the-counter hearing aids. And we're really at the infancy of this. I'd say these are reasonable for people who might have run-of-the-mill age-related hearing loss where it's equal on both sides and it's not a sort of complex hearing pattern. They are certainly less money. I'm not an expert in it, but more and more stores are beginning to quote sell these. The main drawback of over-the-counter hearing aids is they're much less tunable. So really what you're paying for when you buy one of these more sophisticated hearing aids is not just the device, but the person who's helping you fit it really for your hearing. It's not a one size fits all. You can program lots and lots of different settings. And so again, for somebody who has more complex hearing issues or really wants to get the most out of their device, a standard hearing aid that you would see an audiologist for is really the way to go. There are also sort of gadgets, I'll call them, that you can purchase along with your hearing aids to allow you to hear better. One is sort of a microphone. So let's say you're listening to a spouse and you're at a restaurant, you can put a microphone on his or her lapel that will increase the signal, their voice, and decrease some of the background noise. So you have a clear signal coming from them. That's really the main purpose of it. There's different things that you can do. You can wear it on the lapel, you can put it in the middle of the table so you can have more than one person. But all these devices generally work on increasing the signal to noise ratio. That's just a way of saying you get what you want, someone's voice, and that's the signal, and you decrease the background noise from what is happening sort of behind that person. And the only way to really do that are sort of these directional microphones. I should say a lot of hearing aids these days have one or more microphones that are directional. So as you turn your head to different people, those directional microphones also provide some of this benefit as well. And if you were to purchase a hearing aid, you could certainly ask about that. So in terms of choosing a hearing aid, this is really highly variable. Again, I would encourage you to speak to the audiologist about it. I'm on the more surgical medical end of things. I don't do hearing aids every day for a living. So if you have more questions about this, I would encourage you to speak to your audiologist. But there's lots of factors, lifestyle, dexterity. That's an important point with dexterity. A lot of these in the ear hearing aids, if you have difficulty moving your hands and fingers and you're just, as they get smaller and smaller, the buttons on them are harder to press. It might be harder to place a battery, which is something to think about. Vision, that goes along with dexterity. If you have these itty bitty hearing aids that go in the ear and you have low vision, you might want to consider another option. And then there's cosmetic preferences, but I'll tell you, even the ones worn behind the ear, they're really quite difficult to notice unless you're specifically looking for it. So we're going to move on, I'd say, to toward the last third of the talk, which is tinnitus. So the basic definition of tinnitus is the perception of noise when no external sound is present. So the common story that I get in my clinic is someone's at home and for weeks on end, they feel like they are hearing like the rum or drum of a refrigerator. And then something comes up and they ask their spouse, I think we need to fix the refrigerator. It's making all this sound. And the spouse goes, I don't hear anything. And so that's a very common story for how people eventually figure out that what they're hearing is this phantom noise of tinnitus. So it can present anywhere from a ringing to a buzzing, hissing, clicking, pulsing, hearing music. It comes in all sorts of flavors, I would say. There's really no distinguishing features in terms of consequence of the quality. with the caveat that if it is pulsatile, like your heartbeat, that can be a different type of tinnitus that requires a different workup. So if you were to have a clicking or pulsing or whooshing that you measure your, so you put your finger on your wrist, you feel your heartbeat, and this is going in synchrony with your heartbeat, that's a different sort of workup. But the rest of it, I often tell patients it can sound like anything, again, and it really has no consequence. Similar, low volume, high volume, doesn't matter. People want to know if you lose more hearing, is it going to get louder? The short answer is no. There's no relationship between volume of the tinnitus and hearing loss. The best analogy that I can sort of give is like a TV that's not attached to a cable box. So back in the day when we had cable boxes and you would put on the TV, if the cable box isn't on, you would just see like snow. It would just be this random arrangement of black and white pixels on the TV. And the reason for that is the TV is looking for a signal and the cable box is not providing it. But as soon as you turn on the cable box, you have a high definition view of whatever you're watching. It's similar with the brain and the ear. In this analogy, your brain is the TV and the ear is your cable box. If everything's working accordingly and your cable box, your ear is working, your brain is receiving a high quality input. But if the ear has a hearing loss for whatever reason, the brain is searching for some quality signal that it's not getting, and instead it's making up its own noise. So that's why generally what we think of in 2024 is the reason behind tinnitus. Something also to consider is temporary, intermittent, or chronic in nature. It's very common for people to have tinnitus for a couple seconds, minutes, even hours, and then it goes away. That can occur. What you really should get worried about is if it goes on for days and days, that is new. That's something to think about. But again, it's very common, even physiologic, to have momentary tinnitus that goes away. So tinnitus is quite common. 10 to 15% of the population experience tinnitus. I'd say the vast majority of people would describe it as non-bothersome. They say, yeah, I hear this thing in my ears or my brain, and I just don't think about it. Like it's there if I concentrate on it, but for the most part, it doesn't bother me. Sort of like a chronic pain anywhere else in your body. Like you just have it, it's fine, and you just sort of move on. 15% we would probably categorize as bothersome. This sort of means that it affects your day-to-day function. You have difficulty with work or with school or with sleep. You just find it annoying to the degree that it's impacting your daily life. That's, a much smaller percent of the population. And then, at the very top of this pyramid, 5% really is debilitating. So those are the people where they can't work, they can't sleep, they really can't even necessarily leave the house because it's so debilitating. And that's really a minority of patients. I will say that many of these individuals have other maybe health-related concerns going on, and the tinnitus sort of exacerbates those health issues, and those health issues exacerbates tinnitus. So again, this is really a minority of individuals. So he spoke a little bit about what causes tinnitus. I described it initially as hearing loss. That certainly can cause tinnitus, noise exposure leading to hearing loss. Aging, probably also connected to hearing loss or just degradation of the signal itself. There are some psychological issues that predispose people to tinnitus, things like anxiety, stress, depression. It's been studied, and those people are probably more likely to have tinnitus or bothersome tinnitus than the rest of the population. Ototoxic medication, so basically medications that might do damage to the inner ear. We commonly think of cancer treatments like chemotherapeutics. Cisplatin is the most common example of that. There are certain types of antibiotics like gentamicin, which really aren't routinely given these days, but are also toxic to the inner ear. And there are lots and lots of other medications that are thought to be damaging to the inner ear. I will say that if you Google pretty much any medication, you'll probably find some association with tinnitus. It's probably not necessarily related to the medication, unless it's sort of known as a major cause of it. But tinnitus being common, and certain medications being common, it's not surprising that it might be associated with each other. There are other medical reasons why you might have tinnitus, and that's why it's important to at least be evaluated once by your primary care doctor, otolaryngologist, or audiologist. You can have issues with your inner ear, such as a vestibular schwannoma. That's a basically benign lesion of the inner ear, some of the nerves that go from the inner ear to the brain, which I showed you initially. This is not cancer, but sometimes it can cause hearing loss and tinnitus, or other medical issues, Lyme disease, high blood pressure, ear infections, even musculoskeletal things can cause tinnitus. There's a link between issues with your jaw joint or even with your cervical spine or neck that can cause or exacerbate tinnitus. So lots and lots of different reasons. We sometimes think of tinnitus like the alarm system or the fire alarm for the body. Once you figure out that it probably doesn't have any worsening, or I should say worrisome cause through testing, like I just described, oftentimes your tinnitus will be louder when other medical issues come up. So if you have other stressors medically or other stressors in life, the alarm system goes off, your tinnitus becomes roaring, but when you address those other medical issues, or you have less anxiety, or you're maybe less depressed, or you're just relaxed in general, the tinnitus might be less bothersome. So again, you can also think of tinnitus as an alarm system for something else that's going on. So there's lots and lots of different things that unfortunately can cause tinnitus, and tinnitus can cause. So this is just a little pie chart describing some of those things: anxiety, social isolation, unable to work, depression, and then these other things, sleep issues, trouble concentrating. And so there's really a wide range. And I see that in my clinic as well. I would not say that I specialize in tinnitus, but if you treat patients with hearing loss, it's part of your day in and day out. And I have a range of individuals who I ask them about their tinnitus, and this ranges from, yeah, it's there, to basically, unable to work. But again, that's the minority. So what's the treatment approach to tinnitus in 2024? I'll cut to the end. There really are not many great treatment options, but there are some that have data to suggest that they work. So this is what I tell patients, and comes from not me, but our academy, the American Academy of Otolaryngology, Head and Neck Surgery, has put out some guidelines for the treatment of tinnitus that is backed by data. And the first is education. So some people just want to know that there's nothing else going on. They don't have a tumor. They don't have any other medical issues. They don't have any other hearing issues. And a lot of people, you just tell them you have run-of-the-mill benign tinnitus. We're not really sure why you have it, but we're pretty sure you don't have anything else going on. For the vast majority of patients, that's what they want to know, and they eventually feel better. And when they know that the tinnitus is not worrisome in terms of organically life-threatening or something else worrisome, the tinnitus tends to abate a bit. Distraction devices. So this is what we would describe as white noise. So air conditioner, TV, radio, fan, white noise machine, basically something to distract your brain by playing another sort of sound. And this is probably what we recommend initially, and has reasonable success. Hearing aids technically fall into these sort of masking or distraction devices. So if you have hearing loss and your things are much more quiet because you can't hear as well, the tinnitus might be louder. But if you wear a hearing aid, you're bringing in more sound. The environment is less quiet. And so again, that distracts your brain from the silence, and the tinnitus might again be less bothersome. Some newer hearing aid devices also have those tinnitus masking features. Well, they'll sort of play a sound that might be similar to what your tinnitus subjective experience is like. And some patients find this extra bit of tinnitus therapy is helpful, and that's built into certain hearing aid devices. As I mentioned before, a lot of C-spine, neck, jaw issues can cause worsening tinnitus or even tinnitus itself. So we often will recommend physical therapy. I will say I don't generally recommend things like chiropractor type work on the C-spine. There's no data to suggest that is beneficial. So really the studies have looked at run-of-the-mill basic physical therapy to help with stretching and muscle strengthening and relieving of muscle tightness. That's generally what we recommend. There are some medications that are available for things like anxiety and depression as it relates to tinnitus, but that doesn't really address the tinnitus itself. So if you're taking an antidepressant or an anti-anxiety medication, that's really just to help you cope with those other diagnoses. It's not going to rid you of the tinnitus. Then there's behavioral therapy, things like cognitive behavioral therapy, which are aimed at, again, mostly coping strategies to mitigate how bothersome tinnitus is. And there are some pretty good ones out there that if you do have other issues as it relates to tinnitus and you just can't cope with it, as opposed to going down a pharmacologic end, if you wanted to do a more behavioral therapy approach, you could consider that. Basically, everything that I did not mention, I would categorize as experimental. People often ask me about marijuana or CBD or gummies. There have been some studies that have looked at that, and frankly, it could make the tinnitus worse. So I don't generally recommend it. Acupuncture, it's usually 50-50. I really haven't heard of it making it worse. It just probably is either neutral, it might make it better. I see very little downside with acupuncture. So if you wanted to try, you certainly could. There is a newer device that people might have heard of or reading about where you oddly enough stimulate the tongue while playing a sound in the ear. This is called bimodal stimulation. There are a couple of manufacturers of this that have received FDA approval for this approach. I think the data still needs to be there. I don't think any insurances are paying for this, so it's generally several thousands of dollars out of pocket. There might be some benefit. The early neuroscience data is good, but again, until there's more clinical data, it's hard to recommend that on an individual basis. I will say one story as it relates to experimental treatments where I did see a couple, and this one spouse brought another spouse in to my clinic because the spouse was having tinnitus. And the spouse that brought this person into the clinic wasn't so much worried about the tinnitus, but more because the person with the tinnitus went online and paid $800 for some pills that supposedly would alleviate the tinnitus. And my job, as the spouse told me, was not so much to treat the tinnitus, but to get that person to return the $800 bottle of pills. So I thought this was somewhat different and comical, but at the end of the day, I agreed with the spouse and said, please return the magic beans. So don't buy magic beans online. There really is no data to suggest that it works, and it's potentially a waste of money, and who knows what you're potentially ingesting. So again, the things listed above are what have science and data to suggest that they work. So I would go with that rather than shelling out a lot of money. So for those that do go down the tinnitus management pathway, mostly for behavioral reasons, again, this isn't going to necessarily get your tinnitus to stop. It's going to have you feel less stressed about it, fewer emotional reactions, to think less about tinnitus. I oftentimes will tell my patients that you can't meditate tinnitus away. You don't want to go to some silent monk style retreat or yoga retreat and try to get your tinnitus to abate. If anything, that will probably make it worse. You really want to distract yourself from the tinnitus in terms of doing other things, but the more you try to concentrate on it and get it to stop, probably the reverse will happen and it'll just make it worse. So thinking less about it as much as you can by work or other social activities or hobbies are probably the best approach. So that's pretty much it in terms of the tinnitus management from a behavioral perspective. But again, it's things to do to keep your mind off of what's going on. So I think what I'll do now is, open it up to the floor and, happy to address any questions that people might have.
Thank you so much, Dr. Kozin. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding hearing aids. Can loud sounds such as ambulance sirens affect how hearing aids work?
The short answer is hearing aids, for the most part, help to modulate the volume, meaning if suddenly a loud sound was to be played, oftentimes it will decrease it to a certain extent. So generally, let's say if you hear a huge siren, many hearing aids will figure out that what you're listening to is very loud and modulate what your ear is actually hearing. That said, it's if you're next to a siren, irregardless of what the hearing aid is doing, you're still going to hear that volume, but it shouldn't necessarily be amplified much more beyond that.
Thank you. And what are your thoughts on small wireless devices like Apple AirPods or other earbuds? Do you think those are a good first step in helping with hearing loss?
I think the first step should just be seeing your primary care doctor or an audiologist or otolaryngologist. I don't, I'm all for sort of self-treating, but sometimes it could be something as simple as wax in your ear. So what I would generally recommend is just see someone initially, make sure there isn't anything else concerning going on. And then yes, if the recommendation is eventually to try hearing aids, patients ask me all the time about the newer features on, I'd say, consumer electronics, things that you can buy yourself. And I say, go for it, try it. There's no downside. They're certainly less expensive. There are apps that some of these things come with, so you could try it, but don't be surprised if it doesn't get you to where you want to be. So sure, go for it, but just get a medical evaluation twice. I can't tell you the number of times I see patients who are complaining of hearing issues and I look in their ear and there's like a Q-tip there, like I kid you not, for probably years, or just really bad wax. So, the simplest thing would frankly just to have someone start with a basic evaluation.
Thank you. And can hearing aids help with hearing loss in a specific range, for example, 500 to 100 hertz?
Yes, I mean, that is basically exactly what hearing aids are designed to do. So the same way if you have glasses, they're fit to your prescription, they're fit to your eyes. Everyone has different eyes and different prescriptions. That's the same thing with hearing aids. Everyone who might need a hearing aid has a slightly different type of hearing loss. And so if it's low frequencies, high frequencies, all frequencies, what the audiologist will do is fit the hearing aid. Not like people want to say fit, they oftentimes think it's fit like you like literally physically fit it in your ear. That's not really what that word means. Fit means they will program really the hearing aid to your hearing loss. So yes, they will certainly program it to those frequencies.
Thank you. And it sounds like few insurance companies will cover the cost of hearing aids. Are you aware of any progress being made to getting these covered by insurance?
So that's a great question. I'm asked this question all the time. So first, if you're a veteran, I would highly suggest you go to the VA because they have an excellent program where they basically will pay for hearing aids. So if you have any form of military service, I'm not a veteran or connected to that community directly myself, but if you do have some connection, I would investigate because you could end up with free hearing aids. In regard to commercial insurances, I'd say it's a work in progress. It's highly variable and it depends on the state too. So the short answer is yes. I'd say more and more commercial insurance providers are allowing for benefits, and then other people have like healthcare savings accounts and other things that again are highly nuanced and independent. So the simplest way to figure it out is just to call your insurance and see what benefits they might provide. It's a lot better than it used to be.
Thank you. And we have a follow-up question regarding the question that I asked earlier on about hearing aids being adjusted to the specific range. Would this be for a specific type of hearing aid or general hearing aids in general?
Almost all hearing aids that you would get through an audiologist would be that they'll be able to be fit. Again, it's not like a one size fits all where it just amplifies everything. For the ones that you would go through like a reputable hearing aid center, there are certain devices, I'll just call them like pocket talkers. Like you can go on Amazon and for like $100, you can get some device that you put in your ears and you wear something that's connected to a wire that you wear in your chest as a microphone. That would probably pretty much amplify everything. I mean, it's just like across the spectrum. So aside from the very, I would say, inexpensive pocket talker type devices, if you're going to go to an audiologist, they should be able to program it to your hearing testing.
Thank you. How does one get an infection in the inner ear, and can that lead to tinnitus?
That's a good question. So there's different, I would say, types of what we call inner ear infections. I would say they're extraordinarily rare. Like what people usually the type of quote inner ear infection that we might think about is something that's causing other issues as well. So things like meningitis, like things where you're just floridly sick, have lots of other medical issues going on, issues with your brain, which is connected to your ear, and you can have a hearing loss as it relates to that. We don't really commonly speak about inner ear infections because it's like almost impossible to diagnose it. When people have a sudden hearing loss, we often think of it as a type of virus that infects the inner ear, but we never really call it an inner ear infection. We more call it a sudden hearing loss, and we think of it as due to a virus or due to a blood clot or something else. And so it sort of gets a little to a sort of nuanced answer as it relates to tinnitus, but anytime you might have hearing loss either due to meningitis causing an inner ear infection, or hearing loss due to a sudden hearing loss that theoretically might be due to a virus, that's when you might develop tinnitus. It's not so much the infection itself, it's more the hearing loss, which tips the scale for the brain to not receive that signal to then create this phantom noise. So again, hearing loss and tinnitus we think about in 2024 as sort of opposite sides of the same coin, that it's really for the most part, we think of hearing loss as causing this brain dysregulation that is creating this phantom noise. It was a long-winded way of saying yes.
Thank you. And you had covered information regarding how hearing aids can help with tinnitus. If so, do people seem to have better results with one type of hearing aid versus others?
Sorry, say that one more time.
It was
I'm
a question regarding hearing aids for tinnitus. You were saying
Yeah.
earlier on how it can help with that. If so, do people seem to have better results with one type of hearing aid versus others?
It's highly variable. I'd say the data on the improvement of tinnitus with hearing aids is 50%. That's the number that I quote people. 50% of patients with tinnitus will like it. 50% will say it's not providing any benefit. And there's so many different types and styles of hearing aids that I don't think there's one type that is better. It's more, they're all largely the same at the end of the day. If I wouldn't go shop around for the best tinnitus masking features, they're largely going to be the same. But if one works, another one will work. If one doesn't work, another one probably won't work. So I wouldn't necessarily spend a lot of time or money with different devices figuring out if it will help.
Thank you. Are there different or additional concerns in pulsatile tinnitus with respect to age when it occurs? For example, a younger person in their 20s or 30s?
That's a good question. Not really. Pulsatile tinnitus is really a separate category of hearing issues. The main concern with pulsatile tinnitus, and by that we mean basically like, again, some sort of ringing or whooshing or tapping in your ear that goes with your heartbeat, is that it's really a vascular issue. So your heart sends blood vessels to the brain, which travel through the neck, and for whatever reason, they travel through the ear. So the carotid artery and jugular vein go through the ear, literally within millimeters of the hearing organs. And sometimes if there's a disturbance in the blood flow of those vessels, either in the neck or in the ear or in the brain, the ear can pick up on it. They will hear what we call non-laminar flow. Basically, you can hear irregular blood flow in those vessels. And so when somebody describes this pulsatile sensation, we oftentimes will order vascular imaging. We'll order either ultrasounds of the neck to look at vasculature in the neck, or even CT or MRI scans that look at vasculature in the head and neck. And the main thing to do is to look for things like blockages, like atherosclerosis, or even times people can have little aneurysms, not to scare anyone. It's incredibly rare, but you can basically have like outpouchings of the vessels themselves because they can become weakened. And again, that causes a disturbance in the blood flow. So the workup for pulsatile tinnitus is really quite different than run-of-the-mill, nonstop tonal tinnitus.
Thank you.
And age, I'll just say, is not really a determining factor. In my practice, if you were 20 or 85 years old, I would order the same tests.
What are your thoughts on taking aspirin? Can that cause tinnitus?
Yeah, there's lots of medication. I'll just put that there's lots of medications that can potentially have a side effect of tinnitus. And it's sure there's some that can, and it's highly dependent on the individual. So again, you sort of have to weigh the risks and benefits of these medications. If it's a really critical medication that you have and it's causing non-bothersome tinnitus, that's, up to you. But if you're taking a medication that maybe isn't as necessary, it won't necessarily have life-altering consequences, then maybe you stop that medication. It gets to me oftentimes not so much for those over-the-counter medications, but for things like chemotherapeutics, where people can really have a loss of, or permanent loss of hearing and tinnitus as a result to these really quite caustic medications. And then we do need to really measure the risk benefit of these potentially life-saving medications to the potential for hearing loss and tinnitus. So it's highly variable. A lot of those other medications that are over the counter, it oftentimes is reversible, like you stop the medication and oftentimes the tinnitus will stop too. So it's probably a slightly different mechanism.
Thank you. We also received a couple of questions regarding potential causes of tinnitus. So I'm just going to combine them together into one question. Does Meniere's disease or COVID cause tinnitus or tinnitus?
So Meniere's disease, for those that might not be familiar with it, is really a disease of the inner ear. It was described over 100 years ago, but we're still not quite sure what the cause is. We think it is most likely due to some sort of metabolic issue with the inner ear. So metabolic meaning things like sodium and potassium as it sort of goes through the cells of the inner ear. And Meniere's disease is really characterized by three things. It's characterized by dizziness, really bad dizziness, not like imbalance, but world-spinning dizziness that lasts anywhere from 20 minutes to 20 hours and is often accompanied by hearing loss, earfulness, or tinnitus. So yes, Meniere's disease can certainly cause tinnitus, but it's just because somebody has tinnitus, I'd say the chance of them having Meniere's disease is not guaranteed unless you're having those other symptoms as well. So unless you're having really bad dizziness or hearing loss with your tinnitus, the chance of you having Meniere's disease is low. In terms of COVID, I guess I'll just shrug my shoulders and say maybe. COVID's been blamed for lots and lots of things. Personally, when the COVID pandemic was in full blast in Massachusetts, when thousands of people were getting infected in 2020, 2021, I did not see an onslaught of patients to my clinic for tinnitus. I mean, and I think my peers didn't either. So whether COVID causes tinnitus, it's possible. Like it's possible that COVID causes lots of other things. but I would not say that is a primary feature of it.
Thank you. We have a question regarding hearing aids. Are there any hearing aids that you can wear when sleeping in case of an emergency call?
That's a good question. The audiologist would probably be the best person to answer that. I will say that generally not. You sort of want to give your ears a rest, or your ear canals a rest when you sleep. You know, you don't want to roll over on it, break it, cause like trauma to the ear because you're leaning on it for 6 hours. Like it's just not physiologic to lean on it, even if your head is back. Like you want to give your ear canal a rest for a couple hours a day, as it relates to a hearing aid. That said, you know, for people who are hard of hearing, there are lots of other devices that can be helpful. Some people wear sort of a vibrational device that if they get a phone call, it vibrates, like they sort of wear it on their chest or on their wrist so that they get that message. Some people have lights that like go on and off. Like these are people more, I would say, on the spectrum of who are really, really hard of hearing. But there are lots of other devices besides hearing aids that you could use in your bedroom when you sleep so that you would wake up, with vibration and lights being the most common.
Thank you. We have a question regarding tinnitus. What is the anatomical or physiological cause of it? And are there current efforts to find or cure the root cause of it? Alternatively, what new things in otolaryngology makes you excited and hopeful for the future?
So we spoke about this a little bit during the presentation, is we don't exactly know the physiologic cause of it, but what we think is going on is the brain is looking for a signal from the ear. And if the ear is damaged in one way or another, it's not sending a signal to the brain. And as a result, the brain is sort of amplifying a missing signal. So again, the brain wants to hear something because it was designed to perceive sound. And if that sound's not coming in through the ear, it's just going to make up its own noise because it's just not getting a quality signal. There's lots of other maybe causes of tinnitus that are due to other things, like again, neck, jaw issues, other medical conditions that can cause changes in the brain that might perceive tinnitus. But for the most part, the run-of-the-mill tinnitus is probably due to a degradation in signal from the ear. There's lots and lots of research going on about tinnitus. Mass Eye and Ear, I will say, is leading the charge on tinnitus. There are at least 2 or 3 investigators who are part of the Eden Peabody labs who spend 100% of their time just doing tinnitus research, both in terms of diagnostics, understanding why tinnitus is happening from a physiologic basis in mice, behavioral studies, physiologic studies, human studies, and then therapeutics as well. So I am hopeful that you know, institutions like Mass Eye and Ear and researchers and clinician scientists can figure out ways to provide relief for patients. So yes, there's lots of research going on, and a lot of it is occurring in Boston.
Thank you. I think we have time for one final question. Can tinnitus be caused by damage to a brain cell?
That's a hard question to answer, but probably, you know, we know from patients who have concussions or TBIs, or even things like multiple sclerosis or other types of by central, I mean brain related abnormalities, can have tinnitus, even in the absence of a hearing loss. So yes, there are things that can occur in the brain in the absence of hearing issues that can cause it. I'd say that the traumatic brain injury concussion studies have shown this quite nicely. Migraine patients will often have normal hearing, but then they'll often describe tinnitus. So people with neck and jaw issues, again, not the brain, but again, yes. So you can certainly have other causes of tinnitus, which is why it's worth seeing, again, your primary care doctor, or an otolaryngologist to try to figure out what might be the case. I will tell you, the vast majority of the time, we'll be able to say, we don't know. And it's frustrating for everyone all around. It's frustrating for the patient. It's just frustrating for the medical provider because you're coming to us for help and we're not able to give you a good answer. But I tell my patients is we can at least rule out the things that it's not. We can rule out the things that might keep you up at night, brain tumor, stroke, other things. And oftentimes we just don't know why. And I generally tell people it's usually better to not know why than to know why. And people don't necessarily love that response, but I think it's the case. Like if you figure out why you're having tinnitus, it's probably due to some disease process that you might not want to have. So it's always better, I think, just to not know why, even though that might be frustrating.
All right, so I think we are at time. Thank you so much, Dr. Kozin, for spending the hour with us. This was extremely helpful. And for everyone who joined today's session, thank you so much. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone.
Thank you.
Have a lovely rest of the day.